Hello, friends. A very good morning to all of you. So, I hope you have some goals set for you this Sunday morning with your preparations going on in full swing. So, please confirm if you can see my screen and if I'm audible. Good morning, Ashfaq, Katimpadu, Art Time, Prateek, all in one, Med Psycho. So, please confirm if my screen is visible and I'm audible. Dr. ZV. Yes, please, waiting for your confirmation. Thank you. Thank you, Derek. So, friends, in this video, we'll be discussing some important questions from pediatrics, which are, more of clinical oriented questions. With, all of the exams now, the FMGE exams, the NEET PG or be it NExT, whatever it is, all of them are moving more and more towards the clinical pattern. So in this short video, we'll be discussing around 20 questions, which are, clinical questions from important topics in pediatrics. And we will be mainly focusing on how do you approach such clinical questions, okay? So how do you sieve the information and come to your correct answer, right? So here we begin. So, the first important message is, these questions are going to be really long ones. Don't get bogged down by the size of the question. Just try to read through the questions, see the important points, and you'll see that they are not difficult. They are similar to the questions that you've been practicing in the past. And they are, if you've, really done your important topics well, you need not worry, right? So, let's see. The first question, a neonate, okay? What is a neonate? We all know first 28 days of life is brought to the emergency department in cardiac arrest. The resuscitation team initiates advanced life support measures. The heart rate remains undetectable. Okay, so heart rate is undetectable despite effective ventilation and chest compression. So you're giving effective ventilation also and chest compressions also, right? So in neonatal resuscitation, if the baby is not improving with effective ventilation and chest compressions, what do you do next, right? So the team decides to administer epinephrine. We give adrenaline or epinephrine as the next step. So the team decides to administer epinephrine. Which of the following statements regarding epinephrine administration in this neonate is true? So basically, this question is trying to ask you about injection adrenaline or use of epinephrine in neonatal resuscitation, in resuscitating a neonate, right? So whether epinephrine should be administered intramuscularly, or the initial dose of epinephrine should be 0.1 mg per kg. Epinephrine administration will have no effect on the heart rate, or the preferred route of epinephrine administration is intravenous. Which do you think is the correct answer? So always read the question. What is the question asking? Is it asking something true or false? Okay, so which of the following statements regarding epinephrine administration in this neonate is true? Okay, right? So I can see some of you already answering the question correctly. Somita, Anshika, Art Time, Sai, Rock Maiti, very good. Okay, so epinephrine should be administered intramuscularly. No, we know that is not the preferred route of administration. The initial dose of epinephrine should be 0.1 mg per kg. No. So the initial dose of epinephrine is 0.1 ml per kg. Okay, of 1 in 10,000 adrenaline or epinephrine. If you write it in mg per kg, what would be the dose? So in mg per kg, the dose is going to be 0.01 mg per kg, okay, per dose. Not 0.1 mg per kg, it will be 0.01 mg per kg per dose, right? Okay. So this second option is not the correct answer. Epinephrine administration will have no effect on heart rate. No. We know epinephrine has got a positive chronotropic effect, inotropic effect. So it's going to increase the heart rate and contractility of the heart. The preferred route of epinephrine administration is intravenous. Yes, we know the preferred route is intravenous, and the preferred vascular access is umbilical venous catheterization. If that is not available, you can use a peripheral vein to give it. Only if you are not able to secure your intravenous access, only then you can give it even intratracheally. Okay, so D is the best answer for this question, IV route. Yes, moving on to the next question. So again, you have a newborn who presents with weakness, okay, weakness and loss of movement in the shoulder, elbow and forearm on one side of the body, okay. So shoulder, elbow, forearm, of one side of the body, there is weakness and the baby is not able to move. The Moro reflex is absent on that side. Of course, if the baby is not able to move that side, how is the Moro reflex going to anyways happen on that side, right? Based on the clinical presentation, which nerve root is most likely affected in this birth nerve injury? So, you're getting asymmetrical Moro's reflex here, right? One side Moro reflex is there, but Moro's reflex is absent on that side. That means one side Moro reflex you're not able to elicit. So, it is asymmetric Moro's reflex, right? Now, asymmetric Moro's reflex we know can be due to some nerve related causes and some bone related causes. So, there can be some nerve related causes like Erb's palsy, which is due to injury to, yes, Erb's palsy. Who will tell me from your knowledge of anatomy? Erb's palsy is due to injury to the upper trunk of the brachial plexus. So, which nerve roots? Very good. So, it is C5, C6. So, yes, Krishan, Ashfaq, Itachi, Rock Maiti, all in one, Dr. Prince, Anshika, Atime, Daniel, very good. So, Erb's palsy can be a cause, or there can be congenital hemiplegia. Okay, right? And there can be some bone related causes like fracture of the clavicle. In fact, clavicle is the most common bone to fracture in a neonate. Or it can be due to shoulder joint dislocation. Okay, unilateral shoulder joint dislocation. So, shoulder joint dislocation, right? So, in the given question, of course, it looks like, birth nerve injury they are asking. So, we'll think of Erb's palsy. So, Erb's palsy we all know is due to C5, C6 injury. So, in this way, they are integrating the basic subjects also with all the other subjects. So, like here, you can see there is an integration of anatomy with pediatrics here, right? So, all of your subjects, you have to, kind of consolidate and study them together rather than studying piecemeal, okay? Right. Moving to the next question. What we have here is a baby born at 29 weeks gestation. That means it is a preterm baby. What do you mean by a preterm baby? So, a preterm neonate is a neonate who is born at less than 37 completed weeks of gestation. Okay. So, this is a preterm neonate born by cesarean delivery done for fetal distress. The neonate develops tachypnea. Tachypnea means fast breathing. Nasal flaring. Okay, there is nasal flaring. And subcostal and intercostal retractions. That means the baby is having respiratory distress, okay, immediately after birth. Chest radiography shows bilateral, so bilateral diffuse ground glass appearance with air bronchograms and poor lung expansion. You can see this chest x-ray picture given here. So, you can see that instead of the lungs appearing black, there is bilateral haziness of the lungs. So, there is bilateral ground glass appearance of the lungs. And you can see these black lines that are there, not the resolution I think is not very clear, but you can see some black lines near the airways here. So, they are called the air bronchograms because there is no problem with the bronchus and bronchioles. The problem is basically with the alveoli, which are collapsed, giving a ground glass appearance to the lungs, and the lungs appear to be contracted, okay. So, what is the best treatment plan in the present case? So, what is your diagnosis here first, guys? So, we can form the treatment plan only if we know the diagnosis. So, we have a preterm baby who has developed, respiratory distress immediately after birth. And the chest x-ray is showing that, there's collapse of lung, collapse of alveoli. So, what do you think of? What is your diagnosis here? Yes. So, Prince, yes, we can get this type of questions in FMG exam, but they would probably be more simpler. Like they would stop at what is the diagnosis here. Okay. They might not go on to the next step. What is the treatment plan? But from this given case scenario and from this given chest x-ray, you should be able to diagnose it. Yes. Tell me what is the diagnosis, Prince and others. So, healthy med talk, you're right. Very good. So, this is a case of hyaline membrane disease or respiratory distress syndrome. So, you should be able to at least diagnose this, right? So, hyaline membrane disease or respiratory distress syndrome, right? Now, for the treatment of hyaline membrane disease or respiratory distress syndrome, we all know oxygen therapy. So, oxygen we do not want to give in excess in preterms because it can cause toxicity, it can cause retinopathy of prematurity. So, oxygen therapy is not the right answer. Surfactant administration and respiratory support, yes. Hyaline membrane disease or respiratory distress syndrome in neonate, what is the basic defect? There is deficiency of mature surfactant, right? So what will you do? Surfactant administration will be done. That will be helpful for the baby. And you have to give respiratory support, which can be in the form of CPAP. What is CPAP? You can be asked the full form also. So it is continuous positive airway pressure. Okay. So you can either give CPAP, or you may need to put the child on mechanical ventilation if the respiratory distress is very severe, right? Emergency surgical repair of tracheoesophageal fistula. No, we are not thinking in the lines of tracheoesophageal fistula here. Only observation at this point of time. No, the baby is having severe distress. You cannot just sit and observe, right? Okay. So moving ahead. Next question. So what we have here is a 3-week-old, okay, so 3-week-old premature baby born again at 29 weeks gestation develops feed intolerance, okay, is not able to tolerate feeds, is having vomiting, okay, and abdominal distension, and abdominal x-rays obtained. You can see the abdominal x-ray right here as shown in the image. Based on the clinical presentation and image, which of the following staging systems is commonly used to assess the severity of necrotizing enterocolitis in this patient? So they are asking about which staging system is used in necrotizing enterocolitis. So even if this case scenario was not there, then also, the question is quite simple here. What is the staging system used for necrotizing enterocolitis? And we know necrotizing enterocolitis is more common in preterm babies. They present with feed intolerance, abdominal distension. So before going to the options, let me show you what this X-ray is showing. So take a closer look. What do you see? Can you see that instead of air being only inside the intestine, you can see that you can see 2 layers of the intestine. So there is air in the wall of intestine also. Not just the lumen, there is air present in the wall of intestine also. So it is known as pneumatosis intestinalis, air present inside the wall of intestine, okay? Pneumatosis intestinalis, okay? Air present in the wall of intestine, and it signifies stage 2A of NEC, necrotizing enterocolitis. So air not just in the lumen, but air inside the layers of the wall of the intestine, so that the intestinal wall is appearing to have a double outline here. You can see double outline, right? Okay. So this is pneumatosis intestinalis. So which staging system do you use for necrotizing enterocolitis? Is it Sarnat and Sarnat staging? No, we know Sarnat and Sarnat staging is used for HIE, or hypoxic ischemic encephalopathy in neonates. What is Silverman scoring system is used for? It is used to quantify respiratory distress in preterm neonates. Respiratory distress in preterm neonates, right? What is Tanner staging used for? I'm sure all of you know that. So Tanner staging is used to assess. Yes, Tanner staging is used to assess. Come on, waiting for your replies. Tanner staging is used to assess the sexual development, okay, of adolescents, right? The sexual development of adolescents. While Bell staging system is the one which is used to, stage the NEC or necrotizing enterocolitis. So you can see the question is pretty simple, but given the, big case scenario and everything, don't get bogged down by it. Read through the question, and you read through the question really very carefully, and you will get the answer easily, right? So moving ahead, what we have here is an 8-year-old child who presents with short stature. Now guys, what is short stature? It is height of the child less than -2 Z-score, or less than 3rd percentile of expected, based on the age and sex of the child. Okay. His upper segment is to lower segment ratio is 1:1. We know normal upper segment is to lower segment ratio becomes 1:1 at 7 to 10 years of age. So this is normal. This upper segment to lower segment ratio is normal for age. So this child is having proportionate short stature. Okay. That means his trunk and limbs are both proportionately or equally short. It's not that the trunk is disproportionately short or the limbs are short. It's not like that. His X-ray of the left hand and wrist showed a bone age of 6 years. So you can see that the child's age is 8 years, but the bone age is 6 years. That means there is delayed skeletal maturation in this child. Okay, so we are getting a delayed skeletal maturation, right? We are getting a short stature that is proportionate. So you have a proportionate short stature, right? The height of his parents is normal. So the parents' height is normal. That rules out familial short stature. It cannot be familial short stature because the parents are not short. It is not familial short stature. However, his parents had a similar history during childhood. That means during childhood, the parents might be having shorter height. Okay. And there is also a history of delayed puberty in the parents. So there's a history of delayed puberty is also there. So proportionate short stature with delayed skeletal maturation, delayed puberty in the parents, and similar history in the parents, we think of constitutional short stature. Very good. Chokshak, Gangaram, very good. Okay, Rock Maiti. So constitutional short stature is also known as constitutional delay in growth and puberty. That means during childhood, the child's skeletal maturation is delayed and child's height is lesser, but the child will ultimately catch up and the final adult height attained will be normal. It is not familial short stature because the height of the parents is normal. It is not Seckle syndrome because Seckle syndrome has a typical dysmorphism, bird-headed dwarfism, microcephaly is also there. It is not achondroplasia because in achondroplasia the limbs are disproportionately short. So upper segment is to lower segment ratio will not be normal in achondroplasia, right? Moving ahead to the next question. Again, don't get bogged down by the size of the question. So a 15-month-old child is brought for a routine well child visit. The child is able to walk independently, but the parents express their concern about the child's speech development. They mention that the child only says a few words and does not seem to be progressing in language skills as quickly as the other children of the same age. Which of the following is the most appropriate next step in the evaluation of this child's language development? So there appears to be some, speech problem or some language delay in this child. Okay. By 1 year, the child should be able to say 2 to 3 words with meaning. By 18 months, the child has a vocabulary of 10 words, right? So, it might be just normal also, or it may happen that, the child is having some hearing abnormality, and you should always screen for that if the parents are having concern about it. Okay. And these few words that they are mentioning, we do not know they are meaningful words or not meaningful words. Okay. And the child does not seem to be progressing in language, right? So it is a close call between referral for hearing evaluation. Of course, we will not do a complete hemogram and renal function test. Observation and reassurance, if the child is able to actually speak 5-6 meaningful words, we can do that. Neuroimaging to assess brain development is not going to help, right? So the child is able to walk independently, but the parents express concern about the child's speech, and the child is able to say a few words and does not seem to be progressing in language. So if they feel that there is no progression in language, we should always give weightage to the parents' concern, and it is better to get a hearing evaluation done. If that is normal, then we will observe the child and reassurance will be given, right? So it is a close call between A and C. If, in the similar question, it would have been mentioned that child is able to speak, say 5 to 6 meaningful words, then we would go ahead with observation and reassurance only. Okay. So you have to read carefully how exactly is the question worded. Now, another very simple question, which is important for everyone again, right? So FMG, be it FMG, be it NEET, be it NExT, these topics remain important for everyone. It is just the method in which they are, crooking it up a little bit and trying to test your analysis skills. So a mother has a 3-month-old baby. She wants to go back to work, of course, and so she expresses breast milk for the baby before going. How long can this expressed breast milk be stored in a refrigerator? So this question is clearly about storage of expressed breast milk. We all know that at room temperature, you can store expressed breast milk for around 8 to 10 hours. In a refrigerator, we can store it for, yes, 24 hours. So most of you have answered it correctly. Shahu Patil, Dibin Das, Dr. Capricorn, Rock Mighty, Dr. Chaudhary, Sudipta Bhomik, N. Kumar, Gangaram. Suman Kurne. So in a refrigerator 24 hours and in a deep freezer at minus 20 degrees Celsius, you can even store it for 3 months. So that is used in the breast milk banking basically, right? So 24 hours is the best answer here. Moving ahead, we have a 34-year-old primigravida lady who is pregnant and wants to get her fetus screened for Down syndrome. So 34-year-old primigravida wants to get her fetus screened for Down syndrome. Which of the following is the best screening test for antenatal detection of Down syndrome? So, you can do screening for Down syndrome during pregnancy. So, nuchal thickness we see in the first trimester. If the nuchal thickness is more than 3 millimeter, then it is abnormal, right? But it has a screening value of only around 70% or so, 70 to 80%. Integrated test is a test that takes into account some parameters from the first trimester as well as some parameters from the second trimester. And we all know, the risk of having a child with Down syndrome increases with mother's age also. So integrated test takes into account maternal age. From the first trimester, it will take into account nuchal thickness and PAP-A, pregnancy associated plasma protein A, and from the second trimester, it will take the quadruple test. So if you do all the things, combine all these things together and calculate the risk of Down syndrome, this integrated test is able to give you an answer in 95 to 97%. So it has a detection rate of 95 to 97%, okay, for Down syndrome. However, triple test. So triple test, we all know what are the three things in triple test. So they are beta HCG, unconjugated estriol, and alpha fetoprotein, right? Okay. So if you do triple test, it has a detection rate of only around 50 to 70%. Okay, around 70%, not more than that. Okay, and quadruple test, if you add inhibin to the above three markers, the detection rate increases to 70 to 80%. But integrated test is the best test out of these, and it gives the best screening test for antenatal detection for Down syndrome. Of course, the confirmation is to be done by a fetal karyotype. Okay, fetal karyotype. So you have to do chorionic villus sampling or amniocentesis and do the fetal karyotype. That is the confirmatory test. Okay. Moving ahead to the next question. So what we have here is a 3-month-old infant, 3-month-old brought to the pediatric clinic for evaluation. The mother reports a history of untreated infection during pregnancy. On physical examination, the infant is found to have a skin rash and bilateral interstitial keratitis. Which clinical findings are associated with the characteristic triad seen in this condition? So mother had some infection during the pregnancy. After the baby is born, baby is having skin rashes and bilateral interstitial keratitis. Does it ring any bells? Yes. So it is of course a part of the Hutchinsons Triad, which is seen in congenital syphilis. So it is, the question is indirectly trying to ask you what are the components of the Hutchinsons Triad that you see in congenital syphilis. So the three components of Hutchinsons Triad are interstitial keratitis, sensory neural hearing loss, and Hutchinson's teeth. So of course the best answer is B here, right? So I can see all of you answering correctly. Dr. Chaudhary, Rahul, Shahu, Sudipta, Dibin, Umam, Rock, Kia, Dr. Chaudhary, Shashu, Anamika, our time. Very good, guys. Right? So enlarged liver and spleen, of course, are not a part of any triad. Painless genital ulceration, again, not a part of the triad. Hypopigmented macules on palms and soles may be seen, but again, they are not a part of the Hutchinson's Triad. So we are midway through. 10 more questions to go after this. So what we have here is a 1-year-old boy who presented with abdominal distension. Paleness of the body, that means anemia is there. Gum bleeding, there might be some thrombocytopenia. There was no history of fever. So we are not thinking of an infective cause here. Okay, no history of fever. On examination, there was massive splenomegaly. So you have to think of the causes of massive splenomegaly. The bone marrow biopsy reveals presence of the abnormal cells as shown in the image. N number of times you've got these questions in various exams. What do you see here? What do you see here? So this is the what cell? Yes, very good, 100 Shubham Sharma. So it is the Gaucher cell. So you can appreciate the crumpled tissue paper appearance or wrinkled paper appearance of the cytoplasm that you're seeing here. Okay, register this image in your mind, and if it comes again, please don't make it wrong. So it is Gaucher cell which is seen in Gaucher disease. Now again the question is being twisted a bit to increase it to the next level. But for the FMG students, if you are able to diagnose it as Gaucher disease, you're through it. Okay. So Gaucher cell we know is seen in Gaucher disease. Which is the enzyme that is deficient in Gaucher disease? So we know Gaucher disease is due to the deficiency of the enzyme glucocerebrosidase. Glucocerebrosidase. Okay, right? So if this enzyme is deficient, glucocerebroside accumulates in the cells, and these are the Gaucher cells. Now, what is the question trying to ask? All of the following have a role in the management of this disorder except. So the question is taking you one notch higher and is trying to ask you about the management of Gaucher disease. So we all know, friends, and there is a except also. Just mind that, right? So we all know enzyme replacement therapy is very much available for Gaucher disease. Dietary modification is not going to help. Stem cell transplant always remains an option in all these genetic disorders. Blood products, of course, if there is anemia and gum bleeding, that means thrombocytopenia, so you might need to give PRBC and platelet transfusion. So dietary modification is the best answer here. Our time, Shahu, Sudipta, Paditar, Meet, Kia Patel, very good. Right. Moving ahead to the next question, what we have here, again, don't get bogged down by the size of the question. A pretty simple and straightforward question, trust me. A 2-year-old child presented to the pediatric clinic with fever and development of painful oral ulcers. The child's parents report that the child attends a daycare, which is a risk factor for all these viral infections which will get easily transmitted from one another. Center where several other children have recently experienced the similar symptoms. On examination, you notice multiple small vesicles on child's palms and soles, as shown in the image below. Based on the clinical presentation and the image, which of the following viruses is most likely to cause this condition? Very good, Sudipta. So again, N. Kumar, Anamika, Shahu Patel, Chaudhary, Suman, Archana, Dibin, our time. So it is typically what you call it hand, foot, mouth disease. There was an epidemic of hand, foot, mouth disease going on in Delhi recently. So hand, foot, mouth disease, a viral infection where you can see painful oral vesicles and all, and you can see these lesions involving the palms and soles and upper limbs. Sometimes it can involve the other parts also. So the most common causative organism for this is Coxsackie virus A16, but other Coxsackie viruses and enteroviruses can also be responsible. Right. Moving ahead to the next question. Pentavalent vaccine and MR, measles rubella vaccine vials were open and the cold chain was maintained and vaccines were not expired. A picture of these vaccine vials is given below. What will you do with these open vials? So if you have opened these vials but some dose is remaining, what do? Discard both, or discard pentavalent and use MR, or discard MR and use pentavalent, or use both MR and pentavalent in the next immunization sessions. So again, all of you are almost answering correctly, barring a few. Dr. Chaudhary, Umam, Mr. Raj, Sai, Gangaram, Sudipta, Danial, our time, Kia. Very good. Okay. So the correct answer, of course, is discard MR and use pentavalent. So we need to know which of the vaccines follow open vial policy. So the vaccines that follow open vial policy, you can use them in the next visit. But the vaccines that do not follow open vial policy, you have to discard the remaining vaccine. Okay. And next time open a fresh vial. So open vial policy. Just remember a few vaccines which do not follow it, rest follow it. Okay. So open vial policy is not followed by, remember, BMRJ. BMRJ. So B for BCG, M for measles or MR or measles containing vaccine, R for rotavirus vaccine, and J for Japanese encephalitis vaccine. So these vaccines do not follow the open vial policy. Once you open these vaccines, you have to use them in that setting only. So you can see this is the measles rubella vaccine. Another clue that you have is, the vaccines that do not follow the open vial policy. The VVM is on the cover, on the cap. So you remove the cap and use it. And you don't have to use it in the next session. So VVM is not there on the label here. While this pentavalent vaccine, you can see this vaccine vial monitor. So this itself is a question. Vaccine vial monitor, okay? That indicates whether the vaccine has sustained heat damage or not. So this vaccine vial monitor is present on the label here on this pentavalent vaccine. Pentavalent vaccine follows open vial policy, so you can use it in the next immunization session as well. Okay, right. Moving ahead, a 3-year-old child with a congenital cyanotic heart disease and an injection systolic murmur in the pulmonary area. So 3-year-old child, congenital cyanotic heart disease, injection systolic murmur in the pulmonary area. What is the disease that we are thinking of? Of course, we are thinking of tetralogy of Fallot. Had sudden worsening of cyanosis and fast breathing. That means the child landed up in a cyanotic spell. His chest x-ray is shown in the picture. Let's see the chest x-ray. So what do you see here? So you see the classical boot-shaped heart. Okay, boot-shaped heart or core and sabot appearance that you see in tetralogy of Fallot. Boot-shaped heart, right? Now, the intensity of the murmur decreased during the episode. So we know whenever a cyanotic spell happens, remember, the murmur decreases or becomes absent. So many important aspects of one disease being covered in one single question, right? So that is, putting things together. As compared to what was there previously, which of the following would not be helpful in treatment? So this question is indirectly trying to ask you, what are the things that you use in the treatment of cyanotic spell? You need to know that. So let us see what happens in cyanotic spell. So we know in tetralogy of Fallot, there is a right to left shunt. Now due to any reason, if this right to left shunt further increases, there is a cyanotic spell. If there is a cyanotic spell, what is going to happen? There is further hypoxia and hypercarbia and acidosis. Hypoxia, hypercarbia and acidosis, right? And the murmur decreases or becomes absent. Cyanosis deepens, right? Then what is going to happen? So hypoxia, hypercarbia and acidosis is there. So what happens? The respiratory center in the brain is stimulated. So respiratory center in the brain is stimulated and there is hyperapnea. Okay, there is hyperapnea and there is further right to left shunt. So what are the things that are going to be useful in treating a cyanotic spell? Of course, you give oxygen because you combat hypoxia. For treating acidosis, you have to give injection sodium bicarbonate. Okay, injection sodium bicarbonate to treat the acidosis part. Right? Respiratory center in the brain stimulation is causing problem. You can use morphine to depress it. Right? And this decrease in systemic decrease in the systemic vascular resistance is causing problem. So what you do, the child can be in a squatting position or a knee chest position, squatting or knee chest position, and you can decrease this right to left shunt by increasing the systemic vascular resistance. What can you use for increasing systemic vascular resistance? You can use alpha agonists like phenylephrine, okay, or beta blockers like propranolol. So these are the drugs which are used in the treatment of cyanotic spell, right? So going back to the question. So what did the question ask? Which of the following might not be helpful? So read the question very, very carefully. Don't just jump to answer. Not helpful in treatment. So we know calcium gluconate has no role in treatment. Propranolol is used, morphine is used, and phenylephrine alpha agonist is used to increase the systemic vascular resistance. So the best answer here is injection calcium gluconate, right? So slightly tricky question, but if you've got your concepts well, you will definitely be able to answer it. Moving ahead, what you have here is a 2-year-old girl child who was brought to the emergency department at 3 a.m. in the midnight. The child presented with fever and cough. On examination, the respiratory rate was 36 per minute, which is not much for a 2-year-old child. We know in less than 2 months, if the respiratory rate is more than 60, it is abnormal. 2 to 12 months, respiratory rate more than 50 is abnormal. 1 to 5 years, respiratory rate more than 40 is abnormal. So respiratory rate is not much here. We are sorted. Temperature is 100.8, which is not very high, but there is some low-grade fever. Saturation on pulse oximetry is 98%. That means there is not much hypoxia also. The child had barking cough and stridor only on crying. Okay, and the child was hydrated, able to drink, consolable. So this appears to be a case of, what is the diagnosis here? Anyone would like to attempt? So mild croup. So I can already see 100 Shubham Sharma answering, Umam, Sai. So mild croup. Okay, and this X-ray you can see shows the steeple sign. So you can see that the airway is narrowed here, just like the steeple of a church. Steeple sign. Okay, steeple sign. So what the next step in the management would be? So next step in management, what would you like to do? We will give a single dose dexamethasone. So we know treatment of choice in croup is single dose steroid. Nebulized racemic epinephrine is not required because it is not a severe case. Nebulized salbutamol and hypertonic saline not going to help, and washings for influenza virus and RSV are not going to help in your management, right? Moving ahead, what we have here is a 3-year-old boy who was brought with chronic cough and foul smelling stools. There is a past history of hospitalization 3 times with fever, cough and respiratory distress. So this child is having recurrent pneumonias. Okay. There is a history of sibling who died of similar complaints in the past. Okay. So sibling died of similar complaints in the past, right? And the child was found to have pathogenic CFTR mutations. What more do you need to diagnose it? Yes. What is the diagnosis here, guys, that we are looking at? बताओ. विकास राठौड़ is asking, क्या हम 100% ऑक्सीजन दे सकते हैं सिवियर एस्मा में? Yes, अगर सिवियर एस्मा with severe respiratory distress है, for that time we can give. Yes. So Manish, very good, you're right. So our diagnosis here is cystic fibrosis. Okay. So our diagnosis here is cystic fibrosis. Because the child is having respiratory symptoms, the child is having stools abnormality, and he had recurrent episodes of pneumonia, and we know it has autosomal recessive inheritance. So a sibling is also affected. So family history is also positive. Pathogenic CFTR mutations are also there. So to diagnose cystic fibrosis, what is checked in the sweat? We check the sweat chloride. So if the sweat chloride is more than 60 milliequivalent per liter on 2 separate occasions, we diagnose it as cystic fibrosis. It is one of the criteria for the diagnosis of cystic fibrosis. So very good, guys. Dr. N. Kumar, Art Time, Rock Maiti, Patidar, Gangaram, Anamika, Manish. So it is chloride. A 3-year-old boy presents to the pediatrician with a history of recurrent urinary tract infections. So recurrent urinary tract infections, guys, can cause, scarring of the kidneys. The child has experienced multiple episodes of fever, dysuria and abdominal pain over the past year. Which of the following diagnostic tests is most appropriate for confirming the diagnosis in this patient? So, recurrent urinary tract infections, we have to think of an underlying cause which is called VUR. That is vesicoureteric reflux, which can lead to these recurrent urinary tract infections, and we need to treat that accordingly. Now, renal ultrasound is not going to tell you much. It will tell you only if there is some hydronephrosis, dilatation of ureter. So in late stages, it might give you some clue. Voiding cystourethrogram, yes, that gives a good idea about the anatomy of the bladder and the ureter and the kidneys, and it will show you if there is a vesicoureteric reflux going on. That means if the urine should go from kidney to ureter to bladder to urethra. But if the urine is going from the bladder to the ureters and kidney, that is called vesicoureteric reflux. Okay. Urine culture sensitivity not going to help at this point of time. Okay. And complete blood count, again, no. So there is a history of recurrent UTIs, but currently child is not having fever and all. So urine culture sensitivity and CBC not going to help much. So this again is a slightly tricky question. So urinary tract infection, if recurrent episodes are there, you need to do further investigations to diagnose the same. And I'm glad to see that you guys are able to answer this. Very good. Correctly. So a 5-year-old girl is brought to the endocrinology clinic with fatigue, weight gain, cold intolerance. On physical examination, the physician notices a diffuse firm enlargement of the thyroid gland. So guys, we all know that we are dealing with hypothyroidism here. Fatigue, weight gain, cold intolerance, not able to, tolerate cold temperature. Lab tests reveal elevated TSH levels and decreased T4 levels. The physician suspects a thyroid disorder in the patient. Which of the following conditions, if present, would most strongly suggest a congenital etiology? So congenital etiology would be present from the birth. So which of these would suggest a congenital cause rather than an acquired cause? So family history of autoimmune disorder, we know autoimmune thyroid disease usually will not present at birth. Palpable thyroid nodule on examination you can get in both, congenital and acquired causes, more commonly in acquired causes. Positive anti-thyroid antibodies in the blood. So anti-TPO antibodies we would, get positive in Hashimoto disease. Okay. Associated developmental delay or intellectual disability. This is a very, very important point. So if the, hypothyroidism has not been picked up early by newborn screening, then the child by 5 years of age is definitely going to have developmental delay or intellectual disability. So if congenital hypothyroidism has been missed till 5 years of age, the child will have, short stature, other features of hypothyroidism, but more importantly, developmental delay or intellectual disability. On the other hand, if the, hypothyroidism is acquired at a later age, by then, the brain development has happened. already. So you will not expect developmental delay or intellectual disability in acquired cases. Okay. So again, a slightly tricky question, but if you got your concepts well, you can surely be able to answer it. So next we have a 10-month-old floppy baby. Floppy means hypotonia. The limbs are all lying loose, completely loose and lax, just like a frog-like position of the legs. A 10-month-old floppy baby was brought by the parents. He was not able to control his neck till that age. So by 10 months, the neck control should have come. Neck control, the partial neck control comes by 3 months and complete by 4 to 5 months, we know. However, the baby was active and alert and was found to have tongue fasciculations. So tongue fasciculations in a floppy baby who is active and alert, we think of a condition that is known as spinal muscular atrophy, which is due to the SMN1 gene deletion, okay, and which leads to degeneration of the motor neurons of the spinal cord, right? Again, slightly tricky case scenario, but you can expect questions from it. Nowadays, you have some newer drugs available for its treatment, making it more important, right? Myasthenia gravis, you will not get this history. You will get a history of, the child is absolutely well during the morning time. By the evening or night, the child has ptosis and other forms of weakness. Guillain-Barré syndrome, the child will have, generalized weakness of all 4 limbs, more of the lower limbs than upper limb, ascending kind of paralysis there, absent DTRs are there, but fasciculations not seen. Duchenne muscular dystrophy, you will get, pseudo hypertrophy of the calf muscles, weakness of the proximal muscles of the limbs. The child might have a Gowers sign positive, but this floppy baby and all, we don't see tongue fasciculations, we don't see in Duchenne muscular dystrophy. Okay. Very good choice. Chetan, nusinersen is one of the newer drugs for treatment of this spinal muscular atrophy. So, the second last question for the day. A neonate was found to have a swelling in the lower back region, as you can see. So this swelling you can see at birth as shown in the given image. Which of the following is false about the condition shown in the picture below? So let us take a close look at the swelling. What is your diagnosis here for the FMG guys? At least the diagnosis is a must. What is your diagnosis here? Waiting for your replies? Yes. So you can see there is a swelling here. And there's a sac-like thing protruding from the back, and inside it you can see something protruding. So some neural components are also there inside it. So it is a form of spina bifida, of course. It is a myelomeningocele. Myelo, because the spinal cord components or neural component is also there inside it. So it is a myelomeningocele, a type of spina bifida. Myelomeningocele, right? So which of the following is false about the condition is the question. Most commonly involves the lumbosacral spine. We know is true. Myelomeningocele most commonly involves the lumbosacral spine. Folic acid 400 microgram per day is used for primary prevention. Yes, for primary prevention, folic acid is prescribed, and it is recommended to be taken by all women of childbearing age. So important. It can be diagnosed antenatally. Yes, if the myelomeningocele is of a significant size, it can be diagnosed by the antenatal ultrasounds, the level 2 ultrasound that is done. Folic acid should be started as soon as the pregnancy is diagnosed. Yes, guys, what do you think? So, ideally, folic acid should be started before planning the pregnancy. At least 1 month before conception, you should start folic acid. No point starting it after the pregnancy is diagnosed, okay? It might be too late because, some women might realize and come up for investigations pretty late, maybe in the 2nd trimester or so. By then, the organogenesis has happened. So folic acid should ideally be started before planning the pregnancy and not after the pregnancy is diagnosed. So D is the best answer out of the given options, right? Okay. And the last question for the day. So let us see who all can answer this. Slightly tricky question, I would say, a bit difficult, but let's give it a try. A 2-year-old boy with multiple bony deformities, including bowing of legs, wrist widening, chest deformity, and prominence of costochondral junction. So all these are features of, yes, all these are features of rickets. So of course we are dealing with a child having rickets. Now we have to take it the next level. We are not talking about what is the underlying cause for rickets, right? Whether it is hypophosphatemic, vitamin D deficiency, or vitamin D dependent rickets type 1 or 2. Let us go ahead. He had a history of delayed dentition, which again is compatible with rickets, and alopecia. Okay. So this may be in some types of rickets we get it. We get it in vitamin D dependent rickets. But let us see. Investigation findings of this child included low calcium, low phosphorus, high alkaline phosphatase. We know in all types of rickets you are going to get normal to low calcium, normal to low phosphate, and elevated alkaline phosphatase in all types of rickets almost. High parathyroid hormone, of course, that also you will get, because if vitamin D deficiency is there, parathyroid feedback inhibition goes away, so high PTH you can get. Normal 25 hydroxy vitamin D, high 125 dihydroxy vitamin D3. So this 125 dihydroxy vitamin D3 we know is the active form of vitamin D. And this is present in high amount. Then why is the child having rickets? Yes. So the child is having rickets because even though this active form of vitamin D is present in high amounts, it is not being able to act due to a resistance at the level of receptors. And that is what precisely happens in vitamin D dependent rickets type 2, where there is a resistance. The receptors are resistant to the action of vitamin D. However much be the amount of vitamin D, it will not be able to act. So even though high amounts of active form of vitamin D is there, it is not able to act. So your diagnosis here is vitamin D dependent rickets type 2. It is not hypophosphatemic rickets because you have high 125 dihydroxy vitamin D2 here, and low calcium, low phosphate can be there, but this active form of vitamin D you don't get in hypophosphatemic rickets. Vitamin D deficiency rickets, of course it is not there because you have normal vitamin D level. So normal vitamin D level in this case rules out vitamin D dependent rickets. It is not vitamin D rules of vitamin D deficiency rickets. It is not vitamin D dependent rickets type 1, because what happens in vitamin D dependent rickets type 1? There is deficiency of 1-alpha hydroxylase enzyme. So deficiency of 1-alpha hydroxylase. So what will happen? The active form of vitamin D will not get formed. In VDDR type 1, the active form of vitamin D, that is the 125 dihydroxy D3, will not get formed. But in this current case, we have high levels of active form of vitamin D3. So it is not VDDR type 1. So your best answer here is VDDR type 2, that is a defect at the level of receptors. So friends, that is all for today. So I hope you got the knack of how to approach these clinical based questions from pediatrics. With your FMGE exams coming up, having this clinical knack, trying to associate things together, being able to identify things and interpret things from a given case scenario, it is going to help you a lot for your FMGE exam as well as for your upcoming NEET PG or be it next. We are ready. So just believe in yourself. The important topics remain important. Try doing your previous year questions, and this PrepLadder new question bank that we have, the QBank 5.0, there we have handpicked and put all such case scenarios for you. It will give you so much of practice for your upcoming exams, for the clinical, more and more clinical oriented exam questions that we are getting these days. So I'm sure if you practice using this QBank, you're going to have, no problem in facing your FMG, NEET PG, NExT, whatever be the name of the exam, you're going to excel it and come out with flying colors. So thank you very much, guys. So I think we've covered quite a lot, and you'll definitely have benefited from this session. So a very happy Sunday, happy reading. Do take out some time to enjoy also. But yes, when you're studying, please give in your 100% and do your best. So all the best, guys. Signing off for today. Thank you.